start sharing my slides. Okay. Right. Okay. Can you see my slides now?
Yes, sir.
Good. Thanks. So I'll turn off my video now because that's going to cover part of the screen. First of all, thank you to the Sri Lanka College of Internal Medicine for inviting me to do this talk today. So I was asked to, in fact, I selected the topic of acute fever and cough and how we should approach a patient in the medicine long case. So basically, I thought I'll start off by explaining a little about what is actually tested in a long case examination. Of course, I do understand that you all come from different medical faculties, and I'm sure that you all have different, slightly different learning objectives or outcomes for the long case. So you should refer to those in your own faculty to know exactly what is expected in the long case. But in general, what we as examiners, like the examiners are the same everywhere, what we generally look for are these things. First of all, whether the candidate can take a history from the patient, although this is not observed, but he or she will be speaking to the patient in private. So it has to be a complete and relevant history, and there must be a good symptom analysis. Then physical examination, again, the candidate should be able to do a complete relevant examination and make sure that he or she picks up all the important physical signs. It's all right to miss a few physical signs, but it is expected that the important ones would be picked up. And what is meant by important really is not so much important for the diagnosis, but actually the ones that are really obvious, easy to pick up. So if a certain physical sign is difficult but important for the diagnosis, that is of course not very important. Even if you miss it, you can still pass the exam without a problem. But the obvious physical signs should be picked up in order to pass, or certainly to get high marks, but even in order to pass. Then the third aspect is clinical reasoning. This is tested by sections such as asking the candidate to make a summary of the patient's history and examination, or create a problem list, or offer a differential diagnosis, and also investigation plan. And then clinical decision making with regard to how you plan to treat the patient, with regard to general management, pharmacological management, and so on, including sometimes associated emergencies. Now, as you know, the patient who is presented to you in the long case would be not an emergency. It will be a very, very cold case, very stable patient. But as examiners, we also sometimes ask the candidate, if this patient came with a certain emergency, how would you manage the patient? So the relevant emergency may be also questioned upon. And then these are the first four things over there are the four important things, but the two at the bottom also carry some marks, although not a large amount of marks, but a certain small amount of marks. Underlying biomedical science knowledge, such as knowledge from pathology, microbiology or parasitology and radiology, and also from nutrition, pharmacology, and so on. I have just mentioned some subjects, but there may be other subjects also which are important. For example, sometimes even epidemiology may be a little important, but these are, of course, these don't carry a large amount of marks. They'll carry a small amount of marks. And then finally, it's also a good place to assess a candidate's communication skills, how good the candidate is in presenting a case, summarizing and presenting a case to a senior colleague, like what we do during the ward rounds in the morning. So that's also important. And these are the things that we basically check. And I thought I'd just start off by listing these things out to you. So let me get on to the patient that I'm going to present today, but I will combine the patient's findings along with some tips about what to do as well. So if you had seen my patient in the long case, as you saw the patient, what would have struck you is that he looked like a young man from a poor socioeconomic background, looked very thin and ill-looking, and doesn't seem very keen to speak to you, seem to be, like not very cooperative. But don't worry about those things. I mean, what you must do is you must basically, when you feel that the patient seems to be not very keen to speak to you, the main thing is to try to establish some rapport by getting him to relax a little. And you should also relax yourself without getting anxious about it. And then, talk a little bit about where you came from and that sort of thing, and try to talk about something general before focusing on the exam itself, or on the presenting complaint itself. And then try to note down some important identification details. So if you had done with this, with my patient, he would have told you that this patient, his name is Suresh Prasanna. He is 25 years old. He is living in Mattakuliya, and he works as a manual laborer in the mining market in Peta. And he's single and lives alone in a slum room in Mattakuliya. So that is the patient's general identification. And the presenting complaint is that he has been having fever and cough for 3 days duration. Now, how do you get the history? The first thing is to ask the patient when he was last well, and the patient will probably say 3 days ago. But then you must not take it for granted that it is 3 days ago. What you should do is ask, what about last week? What about before that? So sometimes what happens when we do that is you realize that patients were actually not well even before that. And, so you have to keep going backwards and backwards until you actually get to the very real beginning of the patient's present illness. That's very important. And then once you identify that real beginning of the illness, ask the patient to start from that beginning. And then when the patient starts to talk, ask a simple question like, tell us what happened. That sort of very open question. And then once the patient starts to talk, don't interrupt. Listen to the patient. That's very important, because we often make the mistake of interrupting the patient too soon. In fact, there was a very interesting study done some years ago, not with medical students, but with actually doctors, which showed that in a Western country, which showed that the average time that a doctor listens before interrupting was only 18 seconds. So that's not even half a minute. And that's a very bad habit. We must let the patient talk, because initially the patient will be giving you very broad general outlines about the illness, and you can get a nice picture about the illness, how long it was there, and whether it's an acute onset or a subacute onset or a chronic one, whether it is continuous or intermittent, whether it is static or progressive. That general picture of the illness would materialize when you listen to the patient just talking about it, and what are the important things that the patient is worried about and cause problems, which might not even come out in a systems review. So that's very important, to just listen without interrupting, and also make a note of all the main symptoms, make a note of the dates and times and the sequence in which they happen, and try to figure out in your head what are the systems involved. And then when you start interrogating, asking questions, ask him for associated symptoms in those relevant systems and their dates and times also. Now you would have got all the main symptoms that patient has had right from the beginning of the present illness. So you have covered the whole present illness right from the beginning, and you would have heard all the symptoms which happened of the various systems. Now your job is to put them all in chronological order. That's very important. And then start analyzing each symptom one by one. When you're analyzing, what you're trying to do is to answer two questions. First question is, what is the organ or the system involved? That's called the anatomical diagnosis, whether it is in the heart or the lung or the kidneys or the cardiovascular system and so on. Second question is, what types of pathology is at work? Pathological types of diseases like nutritional, metabolic, inflammatory, infective, neoplastic, degenerative, etc. So what sort of pathology is going on? And this is all very easily picked up in the history, in the way that in the timeline of the symptoms and how they developed. Secondly, how did the illness affect the patient? The patient's activities of daily living, instrumental activities of daily living, how it affected the patient's employment, or in the case of a student, whether it affected the studies and so on. And what did he do to get some remedies, such as did he try home remedies, any advice from family or friends or neighbors, any treatments from local places like close by pharmacies or dispensaries? Was it Western medicine? Was it complementary and alternative medicine or CAM and so on? And when you tried it, did it work? Was there a good response, or was there any worsening, or was there any improvement, and so on? And what made him to come to hospital now? So this is all very important. The presenting complaint is actually this now, but the whole present illness is much longer than that. Then you go into the other areas of the history to make sure that you don't miss anything. You must go into the past illnesses, medical, surgical. In the case of a female, obs and gynae, treatment history, medical, surgical, everything, all kinds of treatments, complementary medicines, over-the-counter medications, everything, allergies, family history, both about the family structure, and also similar illnesses in the family or any other illnesses in the family. And then we go into this area called the social and occupational history, which is fairly large. You must talk about the diet, consumption of alcohol and smoking and substance abuse, home and the neighborhood, what sort of neighborhood the person lives in, where you work and what the workplace is like, whether there are any things in the workplace which are important, such as, for example, if someone is working in a chemical factory, that might be important in the case of a lung disease, which might cause chemically induced pneumonitis, that sort of question. About sexual history, about pets and hobbies, travel outside home in the last three months or so, and anything else that might struck as being important. And then something which is fairly new that we are now learning to ask is what's called ICE, or ideas, concerns, expectations. Ideas are the patient's own explanations of what happened to him or her, and concerns are what the fears that the patient has about the future. And expectations are what the patient wants from the consultation. It's not just getting cured, but maybe other things like, I want to be cured by next Monday because I have an interview or an exam, or I want to do this without any cost, without too much of a cost because I don't have any money to spend, that kind of thing. Those are all called expectations. Now, after you got all this information, you have to organize the history. That's a very important step, because it's only if you organize the history that when someone listens to it, it would be very easy to understand and analyze. Otherwise, it will be very confusing and it will only give a headache. So what you must do is put all the positives into the history of the present illness if they are relevant to the present illness. Everything positive that you got from the past history, treatment history, anything, you can put into the present illness in some form. You can say this patient has been having a past history of diabetes or whatever into the present illness, because that's relevant to what you're going to discuss in the present illness. And then start at the beginning of the present illness, not with the presenting complaint. So if there are similar episodes which are connected in the past, you must start with those episodes, not with the present episode. That's very important, because otherwise that cohesion is not there and it will be very confusing when you go back and forth. And always go chronologically. That's very important. Go from the past to the present. Don't mix up the time. Don't go backwards and forwards, because it's very confusing to the person who is listening. And try to mention the month, the date, the time, rather than saying, for example, don't say 2 weeks ago. Say around the 6th of January, or in the first week of January, and then the second week of January, and so on, rather than saying 2 weeks ago, 1 week ago, and so on. And then after this arrangement, analyze each symptom and also give important negatives along with the analysis. This will show the examiner how you have analyzed the symptoms, which gives the examiner an idea about your ability for clinical reasoning. And basically what you're trying to do here is try to say whether this particular symptom is coming from the cardiovascular system or the nervous system or something like that. Basically, that's what you're trying to show, what kind of anatomical diagnosis and pathological diagnosis is underlying this. Thereafter, you can go into the other sections of the history, and which are, by now they'll mostly be negatives, or even if they are positives, it will be positives which are not relevant to the current illness or current presentation. And there should not be any surprises for the listening person in the remainder of the history. For example, anything important for clinical reasoning in the present illness should have been given with the present illness rather than being given as a later part in the history, because then it comes as a surprise, and your initial clinical reasoning would then be all incomplete without that information at the very start. Now, how do we as examiners check your clinical reasoning? We check it through listening to your symptom analysis, because we try to see whether you can incorporate your knowledge of pathoanatomy and pathophysiology. And also, sometimes we ask you to summarize the history and examination. That also tells us whether you can do clinical reasoning. You may remember, when you present the history, you talk about the symptom like chest pain and all the analysis of the chest pain. But when you're summarizing, don't say chest pain, but you can give the inference. For example, you can say this patient has myocardial ischemia or angina or ischemic chest pain, rather than just saying chest pain. Because when you're summarizing, you are trying to put everything together into some inference, some conclusion that we have come. And that inference or conclusion is what gives us the chance to see whether your clinical reasoning is good. There's a very nice article I have given the name there, called Oral Case Presentation Guidelines for Third Year Medicine Clerkship, by a professor from University in Washington called Steve McGee. It's an open access article. You can download that free. You don't have to pay for anything. Just type this on the internet and try to download that article. It's a very nice article. It's very good. It gives a very good idea about how to summarize the case before the ward round. So you should use this and practice this during your clinical clerkships, third year, fourth year, professorials, so that you learn how to summarize and present in a very cogent and summary form to your consultant or to your teacher, so that they can see what we have gathered from history examination and also how we have carried out the clinical reason. Another way we test is the problem list, which can be active problems or inactive problems, medical, psychological, and social problems. And then we might ask you to give a differential diagnosis. Try to give about 3 to 5 conditions or syndromes or diseases, not too many. And these are the ways that we test your clinical reason. So what did our patient have? Well, he was last billed on January 7th. He was admitted to hospital on January 10th, and he was seen by you on the January 12th. On the 7th, he had fever with chills, poor appetite, and felt very weak and couldn't work the whole day, so he had to come back early. On the 8th, he felt he had dry gauze with a persistent cough. And that's very important, because if the cough has a pathology which is persistent, you will have a persistent cough. But if the pathology is an intermittent pathology, such as bronchoconstriction, then it will be an intermittent cough. That's why patients with asthma have a cough in the early morning rather than the rest of the day. But he did not have any nasal symptoms or throat symptoms. That is a very important negative. So he stayed at home and took some Panadol for the fever. On the 9th of January, he began producing yellowish sputum, and the fever kept coming back while he was on Panadol, so it wasn't responding well enough. And so he mostly stayed in bed, and he couldn't eat anything. He was just drinking water and staying. On the 10th of January, he felt breathless. When he was walking around, he felt panting and breathless, felt very weak. And then he came to hospital because this was clearly more severe than any illness he can remember. So you can see January 7, 8, 9, 10. What I have described to you is what was happening to the patient in positives. The only negatives are no nasal and throat symptoms. This is very important. The description of the present illness must be full of positives. When we listen to our medical students' histories, we find that they don't have any positives. They only have negatives. They say fever, chills, and dry gauze of previous duration and vomiting, and no this, no that. All the things coming after that is all the no's. So that's not a history. That is all the missing parts. So this what I'm trying to say is you must explore the history in such a way that you can give a account of the present illness through positive things, like what I have listed here on 7th, 8th, 9th, 10th. You can see what the symptoms are, how the sequence of how they appeared and how they became worse. And also you can see how they affected the patient, how gradually he became weaker and weaker and then decided to come because he was also feeling breathless. So that kind of progression of the illness, that timeline of the illness is very important for you to picture in your mind what kind of pathology may be taking place. So when he came to hospital, the story doesn't end there, because even after coming to hospital, we are taking the history 2 days afterwards. So in the hospital, he would say that he was given some injections through the IV cannula, some blood tests were done, and an X-ray was done, and the fever settled, and the cough and sputum became very much less, and he's feeling much better now. And then you can tell about the important negatives. In this case, he said that there was no hemoptysis, there were no episodes of impaired consciousness or aspiration, because that's very important for a lung infection. There's no past history of recurrent lung infection. There's no immunosuppressive medications in the past, or high-risk sexual behavior. So these are the important questions that you would have asked in the past history and social history and so on, which would be negative, which you would now mention here in the present illness, because it is important for the present illness. So now let's do some clinical reasoning with our patient. You can, I mean, it will be very easy for you to conclude that it is the anatomical diagnosis is that there's something wrong in the respiratory system, probably in the lower respiratory tract. Why do I say that? Now, this is where your clinical reasoning comes in. If you look at the respiratory system, it's something that starts with at the nose and ends in the alveoli. And in the history, we found that he did not have nasal symptoms, nasal discharge, nasal blockade. He did not have a sore throat. He did not have hoarseness. So all those things indicate that the nose, the pharynx, the larynx have been all right. When we have a cough, normally if there's upper respiratory involvement like due to a virus infection, you would normally have a sneezing, runny nose, a blocked nose, and a sore throat, and so on. If it's a bacterial tonsillitis, you will have some severe sore throat, especially on swallowing. So these things were missing in this patient. In the lower tract, which is the lower tract is, of course, starting with the vocal cords. In the lower tract, he probably didn't have a tracheitis, because if it's a tracheitis, normally the cough is very painful. And then initially it's a very painful dry cough, and later it becomes a painless productive cough. If it is a bronchitis or bronchiolitis, you'll also normally have a little bit of airway obstruction and maybe some wheezing as well. So this patient, because he did not have any features of the nose and the pharynx and the larynx and the trachea, we could say it's probably in the lower respiratory tract, somewhere very close to the alveoli, and maybe in the airways, we don't know, because he also complained of breathlessness on the last day. So this is the reason why I said that it's probably in the lower respiratory tract. So that's the clinical reason that you must show that. This is an example of using pathoanatomy to come close to the diagnosis. So what about the pathological diagnosis? You could say that it's an infection because he has a fever, and it's probably a pyogenic bacterial infection. Why do I say that? Because number one, he had chills and dry gauze. Now, you can have fever due to various conditions like infections and autoimmune disease and so on. But if it is chills and dry gauze, then very likely it's a bacterial infection. And he also had sputum which is yellow, and that's what makes it likely that it's a pyogenic infection. So we can come very close to a good pathological diagnosis also. It's an infection, probably a pyogenic bacterial infection. So you can see, like we are even ready with some microbiological investigations already with this history. But why is he breathless? That's a very important point, because there was no proper explanation for that so far. So we have to think a little about that. Does he have some past history of asthma? Well, actually, he said he has had occasional wheezing episodes in the past, but he never bothered to take any medication for that. Does he have any pleuritic pain? Which, when you have pleuritic pain with pneumonia, it limits your chest expansion because it's painful, and therefore the patient gets the feeling of breathlessness or difficulty of breathing. He said no, he has never had any pleuritic pain with this illness. If there had been some pleurisy or pleuritic pain, of course, that would make the diagnosis pneumonia, because it means that there is an involvement of the pleura. Could he be having a pleural effusion? That's possible, because when the patient has, for example, a pneumonia and develops an effusion over about 2-3 days later, you get a late onset breathlessness if the pneumonia is very large, if the effusion is very large. So we have to carefully look for evidence of asthma or evidence of effusion when we are examining the patient. Right. So the rest of the history, what he told in the history was that he said that in the past history, there were frequent febrile illnesses with cough for several years, So he's been having recurrent lung infections or chest infections. He also had occasional wheezing episodes, but as I said earlier, he never took any medications for that. But that's very important thing, because if he has taken some medications and the medication happened to be a beta-2 agonist, such as salbutamol, and that improved the condition, then it makes the wheezing very likely due to a obstructive airways disease and a reversible obstructive airways disease such as asthma. So the treatment history would be very important to check with regard to wheezing. So with regard to treatment history, he said he only takes Panadol for these illnesses and sometimes home remedies like Kottamalli and so on. And he might take occasional tablets from a nearby pharmacy if he had some money. He has never had any allergies. Family history, he lives alone. He's not in contact with the family. He does not speak to the parents and his siblings. We will see why very soon. The social and occupational history, he lives alone. He eats from nearby eateries, whatever food that he can afford. Lives in a rented room with no windows, uses public toilet and community tap, and has lots of mosquitoes in the area. He inhales heroin. He says he spends about 1,000 rupees daily for his heroin. That has been going on for about 3 to 4 years. But at the end of the day, he has no money for any cigarettes or alcohol, so he only takes heroin. Previously, he said he used cannabis since his school days. So, it's a classic example of how someone gets to start smoking and cannabis in your adolescence, and then gradually graduate to smoking heroin when you are a young adult. That's the usual story of these heroin addicts. He's a manual laborer in the Manning market. Why does he work there? Because he gets a regular income. There's always some work for him to do. And it's also very easy to get the heroin from that area, because, all the laborers working in that area get cannabis and heroin also supplied right very easily for them from over there. So his life is basically revolving around working and then earning and then using it for heroin, and then maybe it's a little bit of food when you have some money left. He was he had to move out of his family when they rejected him for his habits. So that's why he's not in contact with the family anymore. And when you ask him, he would also tell you that he has had several arrests from the police for various petty thefts as well. So this is basically the social and occupational history of this patient. Right. So if you talk about his ideas, concerns, expectations, he said, I think this is because of my heroin inhalation. He himself said that. And the concern is that I may not be able to work hard again because I'm not strong now, and my lungs may become very weak. That's his concern. So basically, he wants to recover so that he can work hard and continue to earn money, because otherwise he knows he will be in deep trouble. Right, so we go on to physical examination. So what do we do during a physical examination? You must do a very thorough general examination. Look at the general features of the patient, the height and the weight and the BMI, any deformities and things like that. Examine the head and neck very carefully, including mouth. Examine the hands and feet very carefully. And always mention the JACOL, which is jaundice, anemia, clubbing, cyanosis, edema, and lymphadenopathy. Remember, there are 2 C's in the JACOL. And also check whether there are any medical devices such as NG tubes, IV cannulas, urethral catheters, and so on. Then after the general examination, do a very thorough examination of the relevant system that you found out from the history. In this case, of course, it's the respiratory system. So in the long case, we would normally give a case, we try to give a case where only one system is at fault, like maybe cardiovascular system or maybe respiratory system or something. So we won't try to give you conditions or patients with multi-system problems. Even if that happened to be the case, don't worry. I mean, just focus on the most important system for your careful examination. And afterwards, do a quick examination of the other system. So probably the other systems won't have any important physical signs, but the important relevant system will have some physical signs. And we as examiners will be very keen to see whether you pick up those physical signs which are important in this particular patient. Right, so what did our patient have? On general examination, he looked very emaciated, as I said earlier, looked very ill, and he was febrile even to the hand. He had IV cannula. He was not very well kempt. He was not very clean. He had poor oral hygiene, and the important negatives were there. All the JACOLs were negative. Then when we examine the RS very carefully, he had a tachypnea. The respiratory rate was about 18 breaths per minute, and some signs were found over both lungs. He had prolonged expiration with polyphonic wheezes over both lungs, and some signs were limited to the right lower lobe posteriorly. He had reduced chest expansion, impaired percussion note, and crackers. But there were no signs of consolidation, such as bronchial breathing, or pleural effusion, such as loss of vocal tremulas. So this is what we found basically on examination. And so in summary, I would say that our patient is a 25-year-old manual laborer from Mattak, who presented on January 10th with a lower respiratory tract infection. So now, I'm no longer talking about fever and cough because that was at the beginning. Now, when I summarize, I have come very far. I know it's in the respiratory tract. I know it's an infection. So I can give my inference or my conclusion in my summary. He had both chills and rigors as well as purulent sputum, suggesting an acute pyogenic infection. The examination showed evidence of right lower lobe consolidation. So again, you can see I'm not talking about the physical signs individually. I'm just giving my inference or my conclusion. Looks like he has a right lower lobe consolidation. He also had breathlessness and signs of widespread airway obstruction because there was both the symptom of breathlessness and the physical signs of wheezing and prolonged expiration. The past history is significant for regular heroin inhalation and episodes of wheezing. Since admission, he is recovering well, probably on IV antibiotics, because we know that there's IV cannula. So that's your summary. So problem list, active problems. Number one, the most important one is there's an acute onset right lower lobe consolidation, probably due to a pyogenic infection. So that is how you put a problem. You don't talk about cough and sputum as a problem. You have come very far from that. We have been able to give an anatomical diagnosis and a pathological diagnosis, at least as a probable diagnosis. So we can give that in the problem. Second problem is airways obstruction with breathlessness at rest, but without any acute severe asthma, because he does not have features that require immediate emergency treatment. Problem number 3 is recurrent respiratory infections. That's important in the history. Number 4, heroin abuse. Number 5, malnutrition. Number 6, poor socioeconomic status. And number 7, poor social and family support. Inactive problems, he has been a cannabis user in the past and also has had several encounters with the police. That's a forensic problem that I have listed there. That's your full problem list. What's the differential diagnosis? I would say it's probably acute lobar pneumonia, probably due to a pyogenic organism. And the one that comes to my mind straight away is the pneumococcus. That's a common one. But there are other causes like hemophilus and so on as well. But we need to consider immunosuppression as well, because he's a patient who is on heroin. And although he denied unsafe sex, we have to be careful about that. But there's no suggestion of aspiration, any neoplasm, or chronic lung infection with regard to this pneumonia. There may be recurrent lung infection, but not chronic lung infection, because in between the episodes, he was quite normal, quite healthy. So it was not one chronic infection, but several acute infections. And the other differential diagnosis with regard to the obstructive airways disease, it could be due to chronic asthma, maybe he's an asthmatic, or it could be because of heroin-induced obstructive airways disease. So, right, so this is the patient and the clinical reasoning that goes with it. Now we get on to the next section of the long case, which is basically the management of the patient. So what is your investigation plan? So I would say soon after admission, I will look for sepsis, whether the patient is desaturating on the pulse oximeter, whether they are in features of heroin withdrawal features, and also dehydration. And if any of these things were there, it's important that I stabilize the patient. Then after that, I'll do some blood tests such as full blood count, inflammatory markers such as ESR and CRP, renal and liver profile, and RBS and CBS, because all these are very important in any patient who is acutely ill. Now, when you're saying this, you might also have to say what you would expect to see. For example, in the case of an acute pyogenic infection, I would expect to see a neutrophil leukocytosis. With regard to inflammatory markers such as ESR and CRP, they'll be elevated. I would expect to see a normal renal and liver profile because he's not having any other pathologies that I can suspect. And I also want to see that the CBS is normal, because if it is high by any chance, that's a very important thing to find out. The liver profile, renal profile, and diabetes or hyperglycemia, all those things change our management completely, especially with regard to choosing medications and so on. Then I'll also organize some microbiological tests such as sputum and for full report and culture, blood culture. And if it is available, we'll also do some antigen tests with sputum and urine for various pathogens such as pneumococci and mycoplasma and so on. Then, of course, radiology. I'll do a chest X-ray or what is known as a telechest, where I would like to see if there are any changes of consolidation, especially in the right lower lobe. So this is my investigation plan. And my treatment plan, first of all, as I said earlier, I'll stabilize the patient with regard to hydration and oxygenation. I'll give an antibiotic such as paracetamol. It's important to give the patient nutrition. So this patient is at the moment having anorexia. So basically it will have to be very frequent small meals rather than 3 big meals. And that will have to be rich in calories and maybe in protein. And of course, I'll have to get IV access. Specific measures, it's important to start an empirical antibiotic for pyogenic infection. So what sort of antibiotic would I choose? In our ward situation, I might use coamoxiclav or ceftriaxone. These are the usual medications which are available in our wards because normally amoxicillin would be considered probably ineffective because of widespread antibiotic resistance or antimicrobial resistance. So I'll probably have to use either coamoxiclav or ceftriaxone for this patient. If I suspected atypical pneumonia, I will have to add a macrolide such as erythromycin or clarithromycin. But in this patient, it's not really essential because the patient had clear evidence of a localized pneumonia into one lobe and also yellowish sputum. Whereas if you have atypical pneumonia such as mycoplasma or Legionella, you generally have bilateral physical signs such as crepitations, and also you would not expect a pyogenic infection features such as chills and rigors and yellow sputum. But if you say you want to add a macrolide for this patient, that's perfectly all right. It's quite reasonable. It's not something that would be considered bad or wrong. Now, after starting these measures, the next thing is to monitor the patient over the next couple of days or so to see whether the patient is getting better or worse. We must check the response to treatment. That can be done on the basis of clinical features such as temperature or appetite and how the patient is feeling and so on. You can also use blood tests such as CRP if it's available. And also make sure that the IV cannula is fine, make sure it is not obstructed or infected. That's very important because sometimes we miss the infected cannula for several days, which is not a very nice thing. And remember, the patient is a heroin addict, so look for heroin withdrawal. Similarly, other patients, you might have to look for alcohol withdrawal as well. And also during your daily monitoring, the daily ward rounds in the morning, check whether the patient is developing any pleural effusion. If the patient gets better, before the patient is discharged, there are a few other things that you would like to do. One is you can refer to the psychiatry unit for substance abuse, because this may be a good opportunity to get the patient off the habit, because the patient is worried now. He had this concern whether he might become very weak and unable to work. So this may be a good time to get the patient to think about cessation of heroin abuse. So the psychiatry team will be able to make use of that opportunity to try to get him out of heroin. And of course, in Sri Lankan hospitals, if we also had medical social workers, we could have made use of them as well, because they would go to the patient's home environment and try to see how you can help the patient at the home front where the patient is living. Maybe put the patient back in touch with the family if he's giving up the habit, and maybe help him with some income and so on. But of course, unfortunately, we don't have medical social workers in our hospitals who can do this. Maybe in the future, they might be there. So when you're intern house officers or doctors working in the hospitals, if they are available, we can always make use of that as well. Right. So then at this point, the examiners will give you some investigation reports. He will tell you that the full blood count was hemoglobin was 14, white cell count was 18,000, and the absolute neutrophil count was 15,500 with a normal platelet count, and the CRP is 160. So it confirms your suspicion that it was acute pyogenic infection. The CBS was normal, 140, normal liver and renal profile. And the sputum pool report had more than 25 pus cells, which indicates it's a good sample and there's inflammation, and the gram stain was negative. But the blood culture yielded a gram-positive cocci in chains after 12 hours of incubation. So at this point, the examiner will ask you, what is the significance of this blood culture positivity? So you'll have to know some microbiology here to know that it's probably the pneumococcus, because it's a gram-positive coccus in chains, and the fact that it's a significant blood culture growth because it was positive after only 12 hours of incubation, and therefore this patient requires IV antibiotics and very careful management, because as you know, a positive blood culture carries a poor prognosis. This is actually the patient's chest X-ray. You can see in the right middle and lower zones of the chest X-ray, you can see the features of consolidation. There's a heterogeneous opacification. With the diaphragm, hemidiaphragm is seen very clearly. Therefore, it is in the lower lobe rather than in the upper lobe, rather in the middle lobe. So this chest X-ray will be given to you, and you'll have to explain. You have to describe the chest X-ray and say that the important abnormality is the middle and lower zone consolidation without any infusions, which is probably the lower lobe because the silhouette sign shows that the right hemidiaphragm is visible. So that's basically about the main part of the discussion of the exam. But then, as I said earlier, they would also ask a few questions about something from the biomedical sciences or what you call theory. So, for example, they will ask you to describe the chest X-ray. They might ask a bit about the microbiology of community-acquired pneumonia, such as what are the causes of CAP and what are the diagnostic investigations. They might ask about the pharmacology of antibiotic therapy of CAP, especially the antibiotics that you chose. They might ask about the mode of action or common side effects and so on. They won't ask about the dosage, of course. And maybe a little bit of epidemiology and pathology if there's time to kill until the bell rings. Right. So for your own interest, but don't worry about this. This is not for the exam because we won't ask this kind of thing in the exam. It's too detailed. But I think for interest and also because it's important, I just tell you a little bit about heroin inhalation and the lung. People who inhale heroin have some common abnormalities. They have obstructive airways disease, especially early onset COPD and sometimes emphysema. There's an increased incidence of fatal asthma and recurrent lung infections, which, as you heard, our patient had. There are some common associations to keep in mind. They have frequently they have pulmonary tuberculosis. They may be smoking tobacco and cannabis as well, so they can also have their pathological features on the lung. They could be injecting drug users, and if that's the case, they can have all kinds of complications such as infections and granulomatous disease in the lung, or co-infection with HIV, hepatitis B, or hepatitis C. Some common clinical problems with heroin addicts are they are frequently defaultering on treatment, such as anti-TB drugs, and they are also very common malingerers. They frequently come and say they have hemoptysis and so on, just to stay in the ward and maybe steal something from the other patient. So these are things that we get to understand when we work for a long time in wards. There are, of course, some rare abnormalities, such as cardiogenic and non-cardiogenic pulmonary edema, both due to heroin inhalation and also due to withdrawal, pneumothorax and pneumogestium, and sometimes eosinophilic pneumonias, and rarely interstitial lung disease. So that's basically what I wanted to share with you today. I'm sorry I went a little fast because I needed to give some time for questions and answers. I'll try and answer any questions if you have any. And my thanks to my teacher, Dr. Senaratna, who was very, as usual, taught me a lot even those days and even for this presentation. Thank you. I'm open to any questions.
Thank you very much, sir, for that fascinating talk. And I'm sure this is an eye-opener for all the students and what clinical medicine is all about. So I think now the forum is open for the questions. So if you have any questions, you can unmute your mic and you can ask. Otherwise, you can post in the chat box or in the Q&A box. So then I can present the questions.
Sorry, I'm trying to unshare. Stop sharing. Okay. Yeah, good.
So there's one question coming. How many pus cells are considered to be significant in sputum?
In the full report, that's a very good question. In whenever you do a sputum for culture, even if you do not request it, the microbiology team will anyway do a full report as well. And that serves a very important purpose. It tells you whether the sputum sample is a good sample, whether it's actually sputum or saliva. If it's a really good sputum sample with some coming from the inflamed areas, it has some pus cells, at least 15 per high power field. But the more the merrier, about 15, 20, 25, the more the merrier. But generally 15 is taken the lower limit. But remember, sometimes, unfortunately, if the sputum sample has been lying around in the ward for too long, the pus cells might die out. In that case, it might not even be 15. So be very careful when you evaluate that. For the textbook purposes, our answer is 15, but in practical day-to-day work, even if it is 10 or 5, if the color was yellowish, I would still consider it as an important sample. The other important thing is to check whether there are epithelial cells, because if there are lots of epithelial cells, that basically means it's contaminated and not a very good sample. So that's very important, because it's only if it is a good sample that you take the culture report seriously, if the culture is positive. Even if the culture is positive, the sample is not a good sample based on the full report, then we have to be very careful about accepting the culture report. So if the sample is good from the full report, then you have to take that positive culture very seriously.
Thank you, sir. And then there's one other question. So can you re-explain how the anatomical diagnosis varies with the nature of cough?
Right, okay. So let's say if it is a upper respiratory tract infection, you would have cough with some nasal symptoms or pharyngeal symptoms or throat symptoms. And if it is a pharyngitis, the cough will be probably a painful cough. If it is a laryngitis, it will be a painful cough. There will be a hoarse voice and a painful cough. The patient will be very frightened to cough. He will be trying not to cough, because every time you cough, the vocal cords come together and close, and then that explosive opening happens, and that's very painful because they are very tender. The vocal cords are very tender with laryngitis. So it's a very, very painful cough with the patient is trying not to cough, and also the voice is hoarse. In tracheitis, the cough is initially very painful, and the pain is over the sternal area, but it's dry. But about a day or two later, it becomes a loose cough with a sputum production, and the pain goes away. So when the sputum comes, it becomes sort of lubricated, as it were, and the cough evolves from a painful dry cough over the sternum, a pain over the sternum, into a painless productive cough. If it is the small airways, you would probably expect some wheezing as well. And if there's pruritic pain, that is lateral chest pain, which is well localized and sharp and worsening with breathing and coughing, then there's pleurisy or inflammation of the pleura, and therefore you can be sure that there's also alveolar inflammation, and therefore it's a pneumonia. So that's how you try to use these symptoms to try to figure out which part of the respiratory tract is at fault.
All right, thank you, sir. And then there's one question. It is sometimes difficult to get exact dates and times from the patients. So how to overcome this problem? Is asking with regard to history takings.
Yeah. Well, there are two answers that I have to give. One is that you must keep learning how to do it. It's an important thing to do. So it may be difficult for you at the beginning, but you must keep trying. And, you'll have to sometimes ask questions around, parallel questions, lateral questions to try to verify these things, but don't stop trying. Learn the skill. Even if it is not important for you to pass the exam, it's important for you to practice medicine properly. So therefore, try to get these skills which are important for you as a doctor, even if they are not important for you as a final MBBS candidate. So the second answer that I want to give is that you are right in a way. While you are doing that, you must also try to figure out if the answer you get is reliable or not. That's very important in medicine. You try to get the answer, but you also try to evaluate the answer to see whether it's a valuable answer or a non-valuable or a valueless answer, because it's not reliable. So it's okay, you keep trying, and occasionally if you can't get a reliable answer, just forget about it. But if it is a reliable answer, then it's going to be very helpful for your diagnosis. Because if that sort of time, establishing a timeline is very important to establish the pathophysiology of the patient, of the condition. That's very important for your differential diagnosis. diagnosis and investigation and everything.
Right. Thank you, sir. And then there's one question coming regarding microbiology, but blood cultures show cocaine chains. So can we say it is pneumococci as it is diplococci?
Well, no, you can't say pneumococci. You can say it may be pneumococci. It's a streptococcus, obviously. We don't have to say it's a pneumococcus. So when the examiner asks the diplococci would indicate that it's probably pneumococci, but you see pneumococci are also streptococci. So streptococcus pneumoniae. So they'll be found in chains, especially at the beginning. So when you do a culture on the agar plates, you might find the diplococci later on. We don't have to say it's a pneumococcus, but when the examiner says it's gram-positive cocci in chains after 12 hours of incubation, what you must say is, yeah, so it's significant because it's a streptococcus and it's only 12 hours of incubation. So I think this is a pneumococcus because it can be strep pyogenes or it can be strep pneumoniae. You are right, but it's a streptococcus, whatever it is. But most likely would be a pneumococcus. Simply because it is more common than the streptococcus pyogenes as a cause of pneumonia.
Right, thank you. So I think we'll give room for few more questions. So can resolving pneumonia present with fine crepitations?
Well, normally they say it's coarse crackles, but I suppose an occasional case might even have fine crackles. Generally what they say is when it is resolving, it becomes a bit more coarse.
And then in the loan case, should we comment on curb 65 in the discussion on pneumonia?
Sure, if you can, yes. During discussion, you can tell that, yes. That is the easiest way to prognosticate. That's basically used to see whether the patient needs admission to curb 65. Yes, in a discussion, you could say that. That's fine.
Right, okay. So just two more questions, sir. How to ask about sexual habits politely without angering the patient?
I think, again, you must practice this and learn this. And probably the way to go is to make it sound like any other question, to make it sound very natural. I mean, after all, sexual activity is a natural thing. And it's just that the cultural things are making it look very unnatural. But as far as we are concerned, we are doctors. We are trying to figure out these sexual activities and all those things only because we want to talk about the diseases. So for us, it's very natural. And act natural, look natural, and just, ask it naturally. And there's no need to be overcautious when you ask them. You may have to be very careful when you ask if you are a male who is talking to a female patient, especially a female patient who is from a very conservative background. So you have to look very natural and very matter-of-factly and professional in the way that you use the voice, the intonation, the posturing that you have and all those things. Show as much as possible that you are being very professional. And if you do act very professionally and natural and ask the question, even a conservative female would appreciate the fact that the question is asked because it goes to show that you are being very thorough. So that's a very reassuring point for a patient. The patients like doctors who ask very in-depth questioning. They know that you are interested in their illness and trying to get to the bottom of it, and that makes them feel very reassured. This doctor will find out what's wrong with me. That's why he or she is asking so many in-depth questions. That's very good, paying some attention to my problem. So don't worry, don't feel anxious about having to ask it. We are asking it not because we want some gossip, but because we want a medical diagnosis. So keep that in mind when you ask the question. Look very professional and just float it in a very natural sort of way. Don't make it look like a special question. That's what I do.
Okay, right. So let's move to the last question. How to exclude the possibility of pneumocystis pneumonia in this patient?
Well, pneumocystis pneumonia, okay. The illness is very different. It's a more subacute progressive illness lasting developing over about 1 to 2 weeks. And the main symptom is a dry cough. and maybe breathlessness. There's no sputum production and certainly not a yellow sputum. And when you examine, there probably won't be any physical signs. Of course, if the patient is immunosuppressed, there'll be a clue to that in the history, maybe in the medications, like taking prednisolone or some immunosuppressive medication, or on transplant medication, or HIV positive patient, or at least a patient with a history suggestive of being infected by the HIV. And the chest X-ray, of course, will be quite different as well, not the one that I showed you. So on the whole, those are the reasons, those are the basis on which you would separate it from a PCP.
Right. Thank you very much, sir. I think there are many more questions coming up, but in the interest of time, I think we'll stop the Q&A session there. So first of all, let me thank Professor Panduka Karunanayake, Professor in Medicine, University of Colombo, and one of my beloved teachers as an intern some time back, from whom I have learned a lot. So thank you very much, sir, for spending your valuable time and energy on this activity. And I'm sure you have carved many important concepts of clinical medicine in the young minds of medical students. Thank you. And
Thank you very
I
much.
would like to thank the President, Sri Lanka College of Internal Medicine, Dr. Kumdini Jayasinghe, and my Joint Secretary, Dr.